Hi everyone, Michael Britt here. Now, I'm very proud that the Psych Files podcast has been so successful. It passed the 20 million download mark. And a lot of that success is due to my episodes on how you can use proven memory strategies to remember just about anything, from memorizing terms for a test to remembering people's names at a party or a meeting, or even memorizing speeches. It's amazing how useful these strategies are. So, I put all of these episodes into one audio course. The course is called Hippos, Aliens, and Llamas: Quickly Master the Tricks to a Great Memory. And it's available now on avid.fm/memorymaster. All one word. Hello, everybody, and welcome to the Psych Files. Michael Britt here, and I am excited to bring you what I think you'll find to be a very interesting and useful interview. And it is with Dr. Shelby Harris. She is the author of The Women's Guide to Overcoming Insomnia. And sleep and sleep disorders is not a topic I've talked much about on the podcast. So this was really interesting, and we're going to get into some things you may have, all of us, I guess, at one time, certainly me, have had problems with sleep. Not only are you going to get some tips, but you're going to find out, if you're interested in psychology, how the cognitive behavioral therapy approach, which is used with depression and anxiety, how can that approach be utilized to help people get a better night's sleep, overcome their insomnia. All right, so if you have ever had a hard time getting a good night's sleep, getting all that time in deep sleep and in rapid eye movement sleep, then you got to listen to this interview, again with Dr. Shelby Harris, author of The Women's Guide to Overcoming Insomnia. Let's go to the interview. I am talking to Dr. Shelby Harris, and she's the author of The Women's Guide to Overcoming Insomnia. And so I'm excited to have her on there. There's some great tips in the book. Let's start with asking you, if I may, to introduce yourself, your background, and what you do.
Hi, I'm Dr. Shelby Harris, and I run a private practice, a clinical psychology practice in Westchester, New York. I see mostly anxiety and depression patients, but my main area of specialty is behavioral sleep medicine. So I'm board certified in treating men, women, actually babies through 99-year-olds.
Have you ever had a 99-year-old?
I've got a 98-year-old, yes, so we stretch it to 99. But all ages for sleep disorders and sleep treatments without the use of medication. So I do use melatonin very judiciously with some patients for certain things when it's all evidence-based. But really in the sleep field, we try to use evidence-based, non-medication approaches to sleep. So that's really what my main area of specialty is. And before I was here, I was the director of the behavioral sleep medicine program at Montefiore in New York City for over a decade and saw pretty much all insomnia patients day in and day out. So I have a little more variety in private practice, but I still love to treat sleep patients.
I'm excited to hear what I'm going to learn, because my sleep is on and off depending upon the amount of stressors in my life at the time. But Let me ask you the upfront question. So this is a woman's guide. Does that mean I'm not going to find anything of any value? Or what is it what's the unique angle?
I think it's funny. I never anticipated men coming up to me like, so can I look at it too? That's happening more and more. It's the treatment. A lot of the treatment modules are the same, but the reason I wanted to write the book was because I work with so many women who are going through various life stages, especially women who are perimenopausal, meaning that they're in the stage of moving into menopause and their fluctuations in hormones are just all over the place. And there's a lot of just misnomers out there, and people just don't know what's considered normal sleep and not normal sleep for women in different life stages because of hormonal changes. And that's the aspect that I wanted to address. And a lot of women, especially my age, have little kids, juggling jobs. They're just trying to do it all and are sacrificing sleep, and they can't turn their brains off at night. And men can still get a lot out of it. Just the hormonal chapters might not be totally applicable.
No, I definitely do want to talk to you about the sleep stealers, stompers.
Stomp out the sleep stealers.
Okay, so you got yourself a good chapter title there.
There you go.
All right, but let's start with women's hormonal changes throughout the lifespan and how that affects sleep. Can you give us a little overview of estrogen and progesterone?
Yeah, I think the two main hormones that women have that really affect the cycle overall are estrogen and progesterone. So estrogen is mostly made in women's eggs, fatty tissue, adrenal glands, and it's really the main female sex hormone. And it tends to shift in intensity, shall we say, over time. Estrogen is really important in maintaining weight, healthy weight, heart health, bone strength, and it also really helps to bolster good memory and mood and cognition overall. And it's really important for sleep. Progesterone, I like to think of it as the cousin or relative of estrogen. It's made as well in the eggs and adrenal glands, but it's also very important during pregnancy, and it's produced in the placenta during pregnancy. It's really important during pregnancy to regulate a healthy pregnancy. It's also important for bone strength, kind of like estrogen, but it also has been shown to be sedating as well and help to enhance a neurotransmitter in our brain called GABA, which is a very calming neurotransmitter. So progesterone really is necessary to calm us. It's helpful for sleep. And when we find that we don't have enough progesterone, we have more broken sleep, we have early morning awakenings, more anxiety. We're just not as calm overall. So these two things really, the estrogen and progesterone, play together when we're thinking about, say, the menstrual cycle or pregnancy. And with the menstrual cycle, day one is really the first day of the menstrual phase. So a woman has her period, estrogen and progesterone are low. But then after that, things start to rise again. You start to have a rise in estrogen. You start to have a rise in progesterone during what is now considered the follicular phase. During that point, when they start to get much higher and an egg is released, some women start to actually notice at peak levels, they're more drowsy, believe it or not, because they're having more estrogen and more progesterone in their body. And this tends to be a few weeks into the phase. They tend to find that it's actually easiest to sleep at that point. But then once no fertilized egg is found, then you have your period again. And usually a few days before menstruation, for some people, that immediate decline, that sharp decline in progesterone and estrogen because there's no fertilized egg happens. That's when women actually tend to have the worst sleep because there's a massive drop in estrogen and progesterone. So we think about women who have extreme sleepiness or insomnia. A lot of them have it tied to their menstrual cycle right before they get their period, just as they have their period, and then it tends to abate and then get worse again. And that's when there are treatments, behavioral treatments that can be helpful. Seeing your gynecologist can be helpful for medication interventions, but things can be done and should be done.
Now, what happens when we get to the perimenopausal, menopause stages?
Perimenopause is usually, for many women, think it's just a year or two. I hate to say, often it can be 4 to 6, sometimes even as long as 10 years before you have the cessation of a period for a full year. That's really what menopause is. Menopause, once you reach the stage of menopause, that means that you have not had any menstruation for at least a year. So that timeline of your menstruation slowing down, the time length between your period can be a few weeks. It can start to be months, but it can take between 4 to even 10 years. And the average age is usually around 47 to 50 years old. During that time, estrogen, it's just during perimenopause when you're kind of slowing down, estrogen is just all over the place. Spikes, it decreases. Same thing with progesterone. Just the fluctuations are out of control, which is why we often see hot flashes, we see night sweats. Related is insomnia. I mean, that's the biggest thing that a lot of women complain of. The insomnia just in general, they're waking up with their mind racing, but it can also be insomnia because they woke up from a hot flash, night sweats, whatever else might be going on. And then once they finally have a cessation of any sort of menstruation for at least a year, they're not producing progesterone anymore. And the reason is because progesterone is really used for pregnancy. So no more pregnancy. There's less estrogen, but there aren't as many spikes and drops like there were during perimenopause and the phases earlier. So women often find that it comes a little easier for them to sleep once they finally reach postmenopause, but not everyone. Sometimes they just get stuck in a phase of not sleeping, and it just keeps going and going, and then we have to intervene.
So it's sort of like you could get into some bad habits during the actuation phase.
You've got it. So when we think about insomnia from a cognitive behavioral standpoint, a lot of times there can be something that sets it off. It can be anxiety, it can be medical, it could be perimenopause, stress, whatever that might be. But oftentimes what maintains it are the behavioral and cognitive habits that you've developed over time to try and cope with the fact that you're not sleeping well. And that's where CBT is really aimed. It's aimed at trying to change those bad habits, essentially, and that bad thinking or that negative thinking to help loosen the insomnia a bit.
Now, before we get to CBT, you also mentioned GABA is one of those. We talk about them as a neurotransmitter that increases feelings of relaxation. Mm-hmm. What part does that play in this?
GABA is just tied overall to progesterone. So progesterone, when we see progesterone being produced, it's helping to produce more GABA. And GABA, like I was saying, when you're earlier on the phases, when you're younger and you're having more progesterone in your body during pregnancy, think about it. When people are pregnant, they're often very sleepy at the beginning. They have more progesterone in their body. They're having more GABA. It's more calming, even though later in the pregnancy, there's more physical discomfort that can lead to insomnia and more anxiety. But earlier on, there's more progesterone trying to help grow the placenta, grow the baby overall, that they are much more calm. GABA is really important for sleep overall. A lot of the sleep aids, like the common sleep aids that we often see, Ambien, Lunesta, they help to promote GABA production.
Funny, because the other night I was watching the video how alcohol affects us.
Mm-hmm.
It also increases the release of GABA.
Yeah.
But then I guess it shuts down pretty quickly, and
you got
that's why you wake up 2 hours.
Exactly. That is the cycle, the negative cycle that most people get into when it comes to alcohol. Yeah. Alcohol can put you to sleep, but the quality of sleep and staying asleep is often the problem.
Yeah, it's weird. You really just feel like this is it. I'm out for the rest of the night.
Nope.
It's such an intense feeling of, oh my God, I'm gone. And then 2 hours later, you're up. That doesn't have the effect you had hoped it would.
100%.
Let's say you have these unpredictable lifestyle, and some days you can, some days you can't sleep. So then you wind up taking a PM type medication, and then it kind of works, and then you kind of get stuck into a pattern of using them. How can we change that? So a lot of people who listen to the Psych Files are college students. They've heard about cognitive behavioral therapy, but they've heard of it mostly in relation to how it's used to treat depression and anxiety. So I was curious to read the whole chapter on CBT and sleep. So just how about giving us, just in case there's anybody listening who's, well, what the heck's CBT?
Yeah.
If you can give us a brief overview of that, and then kind of segue that into how you apply that technique to people who have insomnia.
Right. So cognitive behavior therapy in general is a type of psychotherapy that has been around since the 60s or 70s. Cognitive therapy is really challenging and evaluating the thoughts that you're having that tend to fuel negative emotions. So let's say you have someone who's depressed and they tend to have thoughts of, no one likes me, I'll never amount to anyone or anything. It's about looking at those thoughts that you're having and evaluating the evidence behind them and seeing whether these are actually true. Because a lot of the times I like to say we have a filter on our kind of glasses that we're wearing. And just because we have thoughts doesn't mean that they're always 100% true. So cognitive therapy really teaches you to look at the thoughts you're having, evaluate whether or not they're true. And if they're not, come up with ways to really challenge them so that it helps to change the emotions that you have that are tied with them. And if the thoughts are actually true, then it's about problem solving and trying to move forward in your life given whatever circumstances that you have. Then the behavior therapy aspect of cognitive behavior therapy is often used. I mean, it's used with depression, whether it's going out and setting goals of things to do, getting out of the house for small amounts of time in the morning, to even just exposure therapy. So if you think of someone who has a bridge phobia, I work with patients who often have trouble going over, like we have the Tappan Zee Bridge near us, or the George Washington Bridge. I work with them on building up slowly so that they can expose themselves to the fear of going over the bridges, so that their anxiety comes to a peak, comes back down, and then it becomes much easier over time. We also do it with OCD, with social anxiety. The behavioral aspect is very effective as well, and CBT combines both the cognitive aspect to challenge your thoughts with going out and doing things to challenge physically some of the anxiety that you're having, and doing experiments to try and do that. So the way I think about behavior therapy, it's hard when it comes to insomnia, you'll see, because it's actually very different. And I think saying CBT for insomnia is a bit of a misnomer, which I can go into in a minute. But when it comes to, I treat anxiety disorders all the time. So I often think of anxiety disorders forming because when you're near something, like let's take a bridge, for example, you're on the top of a bridge, you're driving over and you have a panic attack. What's your natural inclination? It's either to pull over to the side or drive as fast to the other side as you can and then not do it again. And then when you get to the other side, or you've pulled over, you feel a sense of relief. And that sense of relief is so reinforcing that this is something that was scary. See how much better I feel now that I don't have to do it again? That avoidance of it is what keeps the whole thing going. So what we try to get people to do from an anxiety standpoint, whether it's you are fearing exposing yourself to a subway handle because you don't want to touch the handles on the subway because you fear that you might get the flu and die from it, or driving over a bridge, it's slowly working yourself up an exposure hierarchy, whether maybe just going over a bridge is a little too hard at first. Maybe I just have them imagine it at first. Maybe they picture themselves going over the bridge, or maybe we start with smaller bridges, shorter bridges, and we slowly drive together. I've driven with many patients in cars before. We'll go over it, and we go over it over and over again until their anxiety comes to a peak and comes back down without avoiding it. Because if you avoid or do something like turn the music up, open the windows to bring your anxiety down in a false way, what you're doing is actually just giving yourself more of a signal that this is something to be scared of. So you have to experience the anxiety fully, let it come to a peak, come back down. And once you've done that enough that the peak is not as strong, then you move to something a little bit more difficult until you get to the real feared thing, whether it's a bridge, whether it's, a subway handle, dirt, whatever it is for that person. It can be, social anxiety. It can be going into give a talk at work. I've had people do that all the time. And we just slowly build a hierarchy to work our way up. So that, and then you work on the thoughts as well that might be getting in the way of them doing it. And that's how you combine the cognitive and the behavioral part for CBT.
You're talking about things that people do when they're awake. So
yep,
how
exactly.
do you apply this when I'm asleep?
Yeah, exactly. So I find that CBT tends to be a little bit of a misnomer at times for insomnia when they call it CBT for insomnia. The C part for insomnia is very much the same. And what I find really interesting, and I don't know if much data behind it, is that the cognitions that many of my patients, and I've seen thousands of patients with insomnia at this point, the cognitive part that most people have, or the cognitions, are often very similar. So I'd be so rich right now if I could, have $1 for each time someone walks in my office and says, if I don't sleep tonight, I won't be able to function tomorrow. So just that statement alone, and having someone be able to define to me what function means. What does that mean? Does it mean you won't be able to get out of bed? Does it mean that you'll lose your job because you won't be able to perform at work? Does it mean that you'll just be tired, but you'll get 60% fewer things done? What does function mean to you? So teaching people to challenge the evidence behind the thoughts that you're having. Because I always say when we're up in the middle of the night, our rational brain is not really present. So we're often catastrophizing, very black and white thinking, just going to the worst possible conclusion. And we need to teach ourselves to challenge those thoughts and to evaluate the evidence behind them, because most of the time it's not as bad as we think it's going to be.
Yeah, I mean, I can easily imagine. So let's say you've been in that phase of sleeping well, not sleeping
Yeah.
so well. You get into a habit. You're taking a Tylenol, whatever, PM,
Yep.
and then after a while, you may say, yeah, but let's say it's just an hour before bedtime, and you go, yeah, but I mean, I'm not going to sleep if I don't take one of these
Right.
sleeping assistants. It's just
Right.
not going to work. I'm not going to be able to sleep.
Right. They start to then become psychologically dependent, sometimes physically dependent on these medications. And then it's, it depends what the medication is that you're taking as well. But I will tell you, a lot of the PM medications, Tylenol PM, Advil PM, Benadryl, a lot of them contain something called diphenhydramine.
Mm-hmm.
And that ingredient is, a lot of people think just because it's over the counter, it's fine to take. It causes more problems for a lot of people in the long run than good it does. And after 2 weeks, it usually isn't actually working as well as it did when you first started taking it. So in the sleep field, we actually don't even recommend people take it in the long run because it's more of a psychological dependence on it. That's what's really factored in. So people think they need it to sleep. They think that the only way they can guarantee a good night's sleep is with a PM medication or a prescription medication or alcohol or whatever else. And sometimes it's really just them trying to convince themselves of this when they're not actually looking at the evidence behind it.
So you would guide them towards a conversation where you would say, well, what would happen if you didn't take it?
Exactly. What would happen if
I'll
you
be
didn't
up
take it?
all night long.
Exactly. So let's say you're up all night long. And it's not to belittle the problem, because remember, my goal is to get people to sleep more and to get people feeling good. I want that. But it's not about 8 hours. And I think that's the other thing that we definitely address if you want. But people get very fixated on this number 8 because they see it everywhere. But when you try to aim for a certain number of hours, you're just making it worse for yourself. So if you don't sleep tonight, let's say you don't get 7 hours, 8 hours, whatever your goal is, what's the worst thing that's going to happen tomorrow? What's the evidence? What has happened when you've been really bad in the past? What do you fear will happen? Take me through it and let's see. And then let's look at the actual really bad nights you've had and see what really happened. Did you live through it? What happened the next day?
I remember reading one of your examples, and someone might say, well,
Yeah.
I mean, my boss is going to realize that I'm just not there. I'm not at my best. And then, I could get fired. We generally tend to just think the absolute worst is going to happen. We
catastrophize, right? And then you take away that frontal lobe functioning in the middle of the night, and your brain is just going to say, I'm going to get fired. I'm not going to be able to take care of my kids. I'm going to be the worst mom ever. And then what does that do? That actually makes you more tense, more anxious, and guess what? You're going to be up even later. So it's about teaching people to really evaluate the thoughts you're having, whether it's really true, whether you're blowing it out of proportion.
One last thing.
And let's
remember
say
to check
that
out
the
my
worst
memory
thing
course.
does happen.
You can use
Will you
these
live through
strategies
it?
to get better grades on your
Right?
tests.
Maybe you're
to
really
remember
fatigued.
people's names,
Maybe you
and
just
even
don't
help
get
you to
everything
remember those
done
jokes you
at
keep
your job
forgetting.
the next day.
So you will
Can you
be
deal with
amazed.
that? How do we deal with it?
Avid.fm/memorymaster.
Has that ever really happened,
Avid,
though?
AVID.
It's really important to look at it that way.
/memorymaster. Thanks.
Okay, so you structure things a bit in the book. You've got a thought challenge form, challenge questions form, and a challenge statements form.
Yes.
So this is a way to capture each
You
of the
got it.
components. So just tell us a little bit about those.
So the forms in the book really are just, they're very classic cognitive therapy, where it just teaches you to notice whether you're feeling anxious or depressed or whatever negative emotion that you're having. And I mean, because it's a book about insomnia, it's really going to get at sleep-related thoughts. But whenever you have a negative thought, it teaches you to write them down in a very clear way. And then it teaches you to go through specific questions, kind of like I've been addressing a little bit already, to really challenge the evidence behind these thoughts. So what evidence do I have this is true? What evidence do I have this is not true? What's the worst that would happen? What's the most realistic thing that could happen tonight? Best outcome? What would I tell a friend? And it teaches you a way to come up with an alternate explanation or an alternate response to soften your worry about the night, to hopefully change your anxiety and bring it down so you're not catastrophizing as much.
Sometimes I'll be awake at night worried about, I have 2 teenagers.
Oh.
And I'll go, well, what if this happens? What if that happens? And my wife is a therapist. At the very least, she'll say to me, well, look,
right now, you can't do anything.
Exactly. Exactly.
Just sitting
What
here
can you do about it?
What can you do now? I can't do anything right now. Okay?
Right.
Then you might learn to try to put it aside. It's not, I guess in a way, I keep telling myself, it's not unlike the way you might deal with a child who's fixated on something. You sort of show them something, distraction,
Right. There's nothing more you can do in this moment. And a lot of people will say, well, I have to get to sleep. Like they'll start worrying because they're looking at the clock, right? Oh, it's 2 a.m. I have to get up at 6. I have 4 more hours. Can you force sleep to happen? No. Aside from drugging yourself, which is not going to be the best quality, and you might even feel worse the next day, and it doesn't even always work. So let go of it. All you can do is set the stage by relaxing, sitting outside, doing something to pass the time, take your mind off whatever you're worrying about, and sleep will happen when it happens. Accepting that and letting it go is a huge piece of insomnia work. And honestly, I'll tell you this, when we're talking about the cognitive part of the CBT for insomnia, when I see people just at the beginning of treatment, they come in and all they talk about is their worry about not being able to function the next day, how they didn't sleep. They know exactly how many nights they didn't sleep over the week. When I see them a few sessions in and they were further down the road, and they just stop talking about it so incessantly the minute they sit down, even if their sleep pattern at night hasn't changed, I know they're on the verge of getting better because they're not thinking about it and worrying about it as much. Change the thoughts, you change the sleep.
So one of the things that I've done recently is got myself a Fitbit.
Ah, yes.
I mean, one of the things, as I was reading and I saw the forms and I said, yeah, I can see how this would work. But though you do answer this in the book, because one of the things I thought to myself was, well, what if I don't have the forms with me?
Right.
What am I going to do? And I know that there are apps that are built along the same idea. You open the app and you type out, which takes forever on a phone. But what are your thoughts about what am I going to do if I don't have the forms? And do any of these apps do you recommend any?
So it's an interesting conundrum. So I try to make a distinction between insomnia, which is trouble sleeping, trouble falling asleep, staying asleep, and waking too early, versus people who just have insufficient sleep, which basically means that they can sleep a full night. They just don't make it a priority because they're working too many hours or they're binge watching on Netflix or whatever else it might be. So I think that the apps and the watches, I have a Garmin that I use for running myself that I love, and I wear it just out of curiosity. I think they're fantastic for people who don't make sleep a priority. So it makes you a little bit more aware of how much time you're actually spending in bed. So it can kind of kick your behind in shape a little bit and say, okay, you're only in bed 5 hours a night. Maybe you should be getting a little bit more than that. Now, on the flip side, I think they're actually not that great for people with insomnia. And this has been documented in some research that's starting to come out, because insomnia is really, there's a few things that happen with insomnia. Insomnia is a hyper-focus on sleep. So all you're doing now is putting a watch on someone or an app on someone, and all they're going to do is start becoming more obsessed with how many hours of good quality versus not good quality, REM, and often it's deep sleep versus light sleep. And that stuff is really not terribly accurate yet. It's getting slightly better, but it's not a PSG. It's not a sleep study with EEG leads on someone's head, which is how we do it in a sleep study.
I really don't know how something around my wrist is going to be able to tell me whether I'm in REM sleep or not.
It's estimating it based on, it's really just a movement detector. That's it. So it's estimating it based on how much you're moving throughout the night. I think for people with insomnia, like I said, it's been documented in research, it actually worsens the problem. And what I try to do is take the focus away. I want people not looking at their phones, not looking at their watches. I just want an old school alarm clock to be set for the time in the morning that I want them to get up. And it's really a disorder of perception more than anything. So if someone doesn't have a form on them, all I care about is what they I don't need the exacts. I really don't need an exact. All I want them to say is, I think it took me 3 hours to fall asleep last night. I don't know exactly. But if I start seeing their 3 hours over time, their estimates start to become an hour, I know that they feel like they're up less time in the middle of the night. And that's really what matters more than what an actual watch will tell us. Because the watch isn't exact anyways. Mm-hmm. So it's perception of frustration more so than what an actual watch says. People come in and they refuse to do the diaries now, and they're just bringing in Fitbit data. that doesn't tell me what they perceive at night. That just tells me what the watch is picking up on. I want to know what their nighttime perception is.
The other thing I liked is that I could easily see someone who does this diligently after months. They go, yeah, I mean, I got it down. I know I've done it enough times. I don't know that the forms are as useful. So you mentioned something about a card, right, that you carry with you that would have
yeah, the coping card. So that's the other thing. So a lot of times like that, I won't be able to function tomorrow if I don't sleep tonight. Right. A lot of times people have the exact same thought over and over again. So if you notice that you have the same thought over and over, just write a coping card. So on one side, and this is a classic cognitive therapy technique. So on one side of the card, you write the thought that you tend to always have. And then on the other side, you write the challenge statement. The reality is that I might not get everything done, but I'll at least get 50% of the stuff done. It might not be perfect, but I'll get through the day and I will likely sleep the next night. That's it. And you can just take that card out, look at it whenever you start to feel anxious about not being able to do what you need to do. And it hopefully will help to, if you believe the challenge, that's the key. You have to believe it. It will hopefully bring down the anxiety. So you don't have to keep filling out a form. My goal in life is not to have people fill out sleep diaries and challenge forms, for years on end. It's to internalize it. And, you're doing a sleep diary during the active phase of treatment. Once you've really figured out what your ideal bedtime wake time is, you're good to go from then on in. You don't really have to take out a sleep diary unless you start having trouble sleeping again. Then it makes you more honest with yourself.
All right, let me ask you about a couple of these sleep stealers, because some of them I knew.
Sure
You've got
thing.
a list of maybe 20 of them here. Like I know I'm not supposed to have coffee later in the day. The hard one is I know I'm not supposed to have alcohol. I mean, at the end of the night, I like to have, but I like, what people must say this to you, right? But Dr. Harris, I like to have a little drink at the end of the day.
I love my nightcap. Yeah, no, it's fine. I'm not anti-alcohol at all. It's how much and what time. So a glass of wine, let's say, you want to limit all alcohol within 3 hours of going to bed. So if you're not going to bed until 11 p.m., go ahead, have that glass of wine with dinner. Totally fine. But then also be careful, right? Are you having 2, 3, 4? How many glasses are you having? And then it's like, well, why are you having 3 or 4 glasses? Are you trying to deal with your anxiety or to unwind for other reasons? But I'm not opposed to having a glass of wine here and there. But you just want to do it earlier. The reason being is that when you use alcohol, it does make you sleepy, which is fine. For some people, it actually makes them fall asleep too early, and then you end up waking up in the middle of the night or not getting enough sleep. But it also wears off. So the quality of the sleep you get is worse from the alcohol. And then it wears off so fast that your body's essentially waking up saying, give me more. And then you want more to be able to go back to sleep. And then that's a bad habit that you're starting overall. So alcohol puts you to sleep, but really it's not a great sleep aid in the long run. But yeah, have a glass earlier in the evening. That's totally fine, as long as it's not within that 3-hour window. And then the one other caveat too, or the other thing I always add in is like, if you're going to a wedding or something to celebrate and you decide to have a glass or 2 of whatever in the evening, close to bedtime, fine. You just have to accept that you're making a choice that maybe you won't sleep as well that night. Maybe you will, maybe you won't. And if you make that choice and you say, okay, let it go. Let a rougher night of sleep or being more tired, feeling the next day, let it go and just say, okay, I had fun, fine. Now let me move on to the next night.
Now, here's one that I really thought I was doing correctly, but you're saying it's not a good idea. And that is you're recommending exercise, but not before 4 to 6 hours before bedtime. And I always thought work is over and now I'm going to go work out and that'll make me tired and I'll be able to go to sleep better.
So there's a sweet spot. Now, yes and no. So there's a sweet spot. What we find with people who are good sleepers is their body temperature tends to decrease just a tiny bit right before bed and throughout the night until about 2 hours before you wake up in the morning. And that decrease in body temperature signals release of melatonin in your brain and other things to help you get sleepy. People who don't sleep as well, they actually don't have the same sort of body temperature drop throughout the night. If you exercise within that 4 to 6 hour range before your regular routine bedtime, so let's say you're someone who goes to bed at 10 p.m., if you exercise anywhere between 4 and 6 p.m., getting your heart rate up for about 20, 30 minutes, you're actually going to raise your body temperature, and then a few hours later, it's going to start to drop. and then it drops at around the same time as when a good sleeper's body temperature would drop. So you're trying to mimic that body temperature drop that would happen with a good sleeper. But if you do it within 3 hours of going to bed, you're raising your body temperature too close to bedtime that you're actually going to make it harder to fall asleep. You might make yourself tired, but your internal body temperature is too warm that you're making it harder for hormones and other things to come out in your brain to make you sleepy. So exercise, and then people always ask me about exercise in the morning. That's fine. I find it doesn't really make any impact on your sleep overall in a better or worse way. I mean, I think it's good for your sleep because it makes you healthier, but it doesn't really make you fall asleep faster if you exercise in the morning. But if there's only one time a day you can exercise and it's in the morning, go ahead, go do it.
Yeah, I find it hard to exercise in the morning, a little easier at night.
Yeah, I'm religious about exercising in the morning, but that's the thing is if you do it in the morning, you also need to make sure that you go to bed early enough because those people tend to be pretty sleep deprived a lot of the times.
All right, so there's only one more, and before I bring the interview to a close, I like to read, and I know that I'm not supposed to use read an ebook on my computer or my iPad, so for this reason I went out and got a Kindle.
Yeah.
And you talk about blue light. So what's your decision on these Kindle type devices? Is that better than an iPad?
There's a specific, there's so much technology out there, I honestly can't always keep up. But with the Kindle, as long as it's the paper white one, you're fine. That's what I got, so that's fine. The problem with blue light is that our brains think of blue light as essentially the sun. So melatonin comes out as the sun is about to go down, and melatonin loves darkness. And that's what makes us sleepy. That's why we're meant to sleep in caves in dark environments that are cool. However, if you're looking at the sun, it makes the melatonin not come out anymore. And if we're looking at something with blue light, like a tablet, a typical tablet, like an iPad or a computer, TV, whatever that is, you're looking at the sun and you're making your melatonin not come out as well. And it can make it, there's been studies showing that it can delay bedtime by at least an hour in people. It can fragment your sleep throughout the night because you have lower melatonin production levels. And there's a reason that insomnia has skyrocketed in our population since we've had more and more electronics.
All right. Well, listen, thank you so much for setting aside some time.
Oh, it's my pleasure.
This is Shelby Harris and her book, The Women's Guide to Overcoming Insomnia. Even though I have learned a great deal.
Thank you for having me. I very much appreciate it.
So you've got a few videos on YouTube, and the best way to get a hold of you is?
You just go to my website. It's just drshelbyharris.com. I have a bunch of information on there about my practice in Westchester. I see patients privately there. I'm also starting up some groups for women and probably some male groups as well. Sometimes patients like to have other people to talk with about their insomnia, but they're 8 sessions, sort of time-limited, evidence-based sessions. So I'm going to be starting that up as well for some people.
Yeah, I can see how you would want the man in your life to understand and be supportive.
100%. 100%.
Or your partner.
There you go.
Yeah.
But yeah, that's probably the best way to get in touch with me is going to there.
Well, thank you again so much. I really appreciate it. Really interesting book.
Thank you. I appreciate it. Take care.
Okay, you too.
All right, so there you go. Great interview. Thank you so much, Dr. Harris. Really appreciated reading your book. See you on the next episode of the Psych Files. Michael Britt here saying thanks a lot. Till next time, take care. One last thing, remember to check out my memory course. You can use these strategies to get better grades on your tests, to remember people's names, and even help you to remember those jokes you keep forgetting. So you will be amazed. avid.fm/memorymaster. That's avid, AVID.fm/memorymaster. Thanks.